Morning, everybody. Welcome to this meeting of the Board of Directors of Lincolnshire Partnership NHS Foundation Trust. My name's Kevin Nokia and I am the Trust Chair. Now, it's our normal practice to start our board meetings with a patient or staff story. We've got something slightly different this morning in that it is a pre-recorded video rather than having a patient here. So Tracy Jones is here to answer questions and, as it were, to bookend the video. But the video has been made by our learning disability experts by experience. So we'll have the opportunity to ask questions at the end of it. I'm sure Tracy will do a great job of answering those questions, but I think she's undertaken to take any questions that she can't answer away and provide us with a response separately, which is very kind of you, Tracy. Now, I don't know who's in charge of making the video work, but if we could tee the video up, that would be fantastic. Great stuff.
Our presentations are accessible using images and easy text. Everything we say is typed here for those who may have hearing difficulties. We don't usually use acronyms, but for the purpose of this presentation, we have shortened Experts by Experience to E by E. With us today, Peter is our newest recruit and was employed last December as an Expert by Experience. Amy is one of our relative carer E-by-Es and has been working with us for almost a year. And I'm Tracy, and I'm one of the Expert by Experience coordinators for our service, alongside my colleague Susie Westwood. We currently have 6 Experts by Experience employed on a bank contract: David, Della, Peter, David, Amy and Natalie, and we also recruited 3 relative carer Experts by Experience last year: Kate, Claire and Amy. Their experiences are incredibly valuable to our service and the wider trust. They are the voices of the people who use our service. Nearly 7 years ago, our service felt it was time to look at employing people with a learning disability. Research of other trusts showed people with a learning disability were predominantly volunteers or employed alongside an educational course. We needed people who had accessed health services and were happy to share their experiences, good or not so good. We needed their thoughts, ideas, opinions, honesty and passion about improving services. We started by asking local groups, day centres and care homes if anyone would be interested in this role. We provided easy read posters and information about our plans and asked our teams if they knew anyone they had supported in the past who might be interested. We held local events in each team area, meeting potential candidates and giving them information about our trust and service and bank hours, contracts, etc., and asking them to complete a skills and interest booklet. We thought we might get about 5 people turn up, but over the 4 events, we met nearly 40 people who were interested. It was really important to us that we didn't rush the process. We wanted to get it right. We invited everyone to a workshop day. Over 40 people attended. Some of our staff also attended and were placed on each table to support. We provided a quiet room and communication cards on each table. We did some work around what to expect from us as employers and what we expect from employees and what areas of the role they will be interested in. We also gave out easy read job descriptions and application forms for people to complete if they were still interested. Over 20 people were still interested after the workshop event and had completed application forms. We made sure we were very clear that we couldn't employ everybody and prepared people for not getting the job. We decided we wanted the interview process to be very relaxed and informal. We sent the applicants a guide on what to expect at interviews and asked if they had any reasonable adjustments. We offered the job to 6 applicants. Recruitment involvement. We organised a day where the E-by-Es came together and met each other, and a staff member from recruitment attended with all the relevant forms needed to complete the process. Easy read contracts were completed. After a year-long process, we finally had our dream team. Making friends with recruitment. This is a priority. We all know how complicated the recruitment process can be, and since we employed our original e-BuyEs, the process has changed and was no longer accessible or easy. Everything is online, many emails with instructions and requests, which can be incredibly complicated and overwhelming for some people. It took us 6 months to employ a new e-BuyE last year, and Susie spent most of her days trying to support her to answer emails and complete online documents. She said she could not have done it without Susie. We knew we had to work with recruitment to make it a smoother, easier process for our e-BuyEs. We provided feedback about our experiences. We discussed reasonable adjustments, accessible information, and the fact that we needed to be included in the emails being sent so that we could prepare and support people. We also discussed the issues around ID. Many people with a learning disability do not have passports, driving licence, or even personal utility bills if they live in residential care homes. Recruitment were fantastic and listened to everything we said. A huge thank you to Sarah Marshall for working with us on this. We have now produced easy read step-by-step guides, checklists for things completed, and guides and information about accepted ID and other documents. We found out people can apply for a pass card via the post office for £15 if they don't have accepted photo ID. We completed this new improved process with Peter last December, and it was much easier and smoother for everyone. In 2016, a new law was introduced, the Accessible Information Standard. This ensures that all health and publicly funded services meet communication needs and provide information in a format that patients, service users and their carers understand. We produced easy read documents to support the recruitment process for every stage. Reasonable adjustments we needed to think about. Public transport. We all know this isn't great in Lincolnshire. We need to make sure work offered is within bus and train times. Accessible meetings. We produced an accessible meeting pack with easy read agendas, name cards, communication cards, and a guide on how to ensure accessibility with reasonable adjustments. The times of work. Some of our e-BuyEs are not available all day, so we are looking at making changes to things like our interview process. Pre-meets, making sure our e-BuyEs are prepared and are offered pre-meets with the people they will be working with if needed. Staff introduction sheets. Our teams have provided their names, roles, and a brief description of the work they do. e-BuyE introduction booklets. Our e-BuyEs have provided their own introduction sheets and explain any reasonable adjustments they have and the support they will need within their role. Our e-BuyEs participate in adapted mandatory training every year. The leads in each area are supported by Susie to adapt their existing training into an accessible format, and this includes health, safety and fire training, IG and confidentiality, equality and diversity, safeguarding, infection prevention and hand washing, and basic life support. We support staff to understand our e-BuyEs are employed to share their experiences of having a learning disability and using health services. They've gone through their adult life trying to access health services and have a variety of experiences to share. We presented preparation sessions at team meetings, and one of our hubs piloted it for 3 months. Each hub was allocated an e-BuyE who lived close by. They met with the staff teams and were given insight days. We needed to make sure teams understood that it wasn't giving the team extra work, but enhancing what they already do. The e-BuyE links in the hub are there to liaise between their hub and the e-BuyE team. They are not expected to find and facilitate all the work for the e-BuyEs. They gather ideas and requests from the hub and pass these on to the e-BuyE team, who then coordinate the work. The links have access to a Teams folder where information is stored, and we have regular meetings. Our e-BuyEs have all signed easy read consent forms to include everything they do within their role: story sharing, videos, photographs, disclosing their reasonable adjustment requirements, etc. It was important that our e-buyees could choose when they wanted to work. We needed to think about hours worked and how that could affect any benefits. We also didn't want to put pressure on people to work specific days every week, so we offer the work and they choose whether to accept it or not. In the past, some of our e-buyees have required some support from a hub and referrals have been made. As they are our colleagues, this does raise some important questions. In the event of this happening, there are options to support them. They might just want to take a break from their work as an e-buyee while they receive support. Some have in the past been referred to staff wellbeing service. They might still want to work for their own well-being, and they can either work with myself and Susie or in a different hub for the duration of their need. Over to you, Peter.
It is important that the work we do is meaningful and will make a difference in our service. We share our experiences of having a learning disability and using health services, the barriers we have faced and the good experiences. We have helped our service to look at things differently. We are open, honest, and we are not afraid to speak up. All of our e-buyees are involved in the recruitment process in our service and the wider trust. We look at how the person communicates and engages with us. We like to find out more about the person, so we speak to them about their interests and what's important to them. David is very keen to support our nurses with training in GP clinics and hospitals. He has shared his experience of having an annual health check and talks about the reasonable adjustments he needs. He really enjoys meeting people and is very passionate about making sure health staff understand the needs of people with a learning disability. We have completely changed the way we ask people to give us their feedback. It was difficult for people to do it before. They were not really given a choice about how they could give their feedback and when they would like to do it. We have made it much easier. It's called Your Say, Your Way. We've got lots of feedback now and we're nominated for a staff award for this project. We have provided our quality improvement poster for you to look at. David has been promoting the accessible information standard in our service and the wider trust for the last few years. He co-produces our training and talks about the importance of meeting communication needs of people using his own experiences. David wanted to tell you he won't stop until everyone knows about the accessible information standard. We have produced our own presentations and have shared our experiences of health services, communication and promoting learning disability awareness. We attend events and conferences and speaking in front of lots of people. Amy and David have been working with staff in the hubs to make clinical areas more accessible, looking at what we provide to make sure the people who use our service feel safe, comfortable and reasonable adjustments are in place. We provided you with our e-buyee newsletter showing everything we do.
I'm Amy and I'm a relative carer at e-buyee. I've been working in the Learning Disabilities Service for almost a year. Our input in this service is crucial to ensuring the carer's voice is heard. The challenges and barriers we face daily need to be heard, and the work we have participated in during the last year has shown our experiences have been incredibly important to our service. Last year, we all participated in a potential new assessment process. Myself, David and Kate took part in a mock assessment over a few weeks. We were able to provide honest feedback looking at how accessible it was, if it was too overwhelming and what improvements could be made. Claire is really keen to be more involved in how our service supports our relative carers. She has already attended a carer-led meeting and is looking to see how this role can be expanded. Kate recently worked with our positive behaviour support team during their training day. She participated in a potential new assessment and gave fantastic feedback from a relative carer point of view. Kate is also very keen to be involved with contributing to and supporting GP clinics and hospital training. All three of us have been involved with working with an animation company and producing a wellbeing video. We have a very emotional, powerful meeting talking about daily challenges we face and how we cope. We are in the final stages of this and look forward to the results. I am very passionate about transitioning. I have 2 young children, both with additional needs and a learning disability, who will most likely transition into the service. I want to draw awareness to the Learning Disability Service and what they do. I also want to ensure consistency and share my experiences to support the service.
We've had some great feedback from colleagues that our EBIEs have worked with. This is from Physical Health Training Day. Amy and David were so engaged in the learning and were able to contribute a wealth of knowledge to the discussions we had around physical health needs and understanding the need to make reasonable adjustments for people with a learning disability and other people, such as the elderly and children. They also shared some personal stories with the group, and we thank them for this. It's good for students to hear the real-life experiences people have. They both were happy to be actively joining in the learning and in completing the physical health skills, and read out information on the slides to help. Thank you so much to both. It was so lovely for them to be part of the group. For a Relative Carer Insight Day, it was a pleasure to meet Claire. She was so open and honest about her experiences and was really keen to understand what we do in the hub. From some hub work, David brings joy to the hub every time he arrives. I love working with him. Interviews. His input was so valuable and the candidate really enjoyed his questions. He did really well and was very good at sharing his opinions in a professional and helpful way. And more interviews. David was wonderful. I was so nervous, but he relaxed me, asking about me and my life, my interests and hobbies. I could have chatted with him all day. And finally, our EBIEs have been integral in changing the way we work. They've shown commitment, care and compassion, honesty, innovation, creativity, determination and passion with ensuring our service users and carers are listened to and have a voice. I'm very proud of what they have achieved over the last few years, and I'm looking forward to seeing what they do in the future.
Thank you very much, Tracy, for allowing us to watch that video, which was fantastic and quite inspirational. I mean, a couple of quick comments, and then I'll ask colleagues if they want to ask questions or comments. The first is it's really reassuring to see the work that we're doing as a trust to facilitate and support the recruitment of experts by experience. It's really easy to commit to hearing the voice of experts by experience, and then to fall short in supporting them during the recruitment and development kind of process. So that's really reassuring, and I'm always both inspired and humbled, I think, by at the contribution that our experts by experience make. So I'd like to say thank you for that as chair and on behalf of the board. So thank you for letting us, get some real insight into that role in the learning disability context. So thank you. So over to colleagues. Sharon, and if you wouldn't mind introducing yourself before you speak. Thank you very much. Sorry.
Thank you. Sharon Harvey, Chief Nursing Officer. Hi, Tracy. Thank you so much for the video. Just a couple of comments rather than questions from me. I love how even though not all the EBIEs were on the video, I could feel their personalities coming through. And as you know, I'm a real supporter of the EBIE team, so that was fab. I hadn't realised the breadth of work that the team are doing. So I think you've showcased that really well. And I love the fact that the team have done the mock assessments. What better way to really test out what assessments would be like for people to receive and do the mock ones. So I think that's fabulous. Yeah, just thank you to you and the team for making sure that the voice is really heard. And it's great to also see the carers' voice and the development around hearing from our family carers, as well as people with a lived experience in that. And I know the board would be welcome to receive any kind of bits that you and the EBIEs feel we could do better, or if there's anything else, we are always open to that. So if on reflection the team want to feed anything in, I'm happy for you to contact me around any of that. But thank you. Thank you,
Sharon. That's much appreciated.
Yeah, just absolutely echo Sharon's point. As a board, we are absolutely open to being told that we can do things better, Tracy. So,
Okay.
Girish.
Good morning. Thank you, Chair. I'm Dr. Girish Kunigiri, the Chief Medical Officer. Thank you, Tracy. It was really, really amazing. And this really makes our day, how we can help our service users, particularly with, certain neurodevelopmental issues, coming forward and talking about this. So two things from me. One was, from the clinical perspective, we see people with learning disability, particularly in the milder category, coming to the mainstreams. So my question is, in terms of your own involvement and engage with the teams in general in the mainstream, how you and your team are able to influence them, and is there any support, you feel that would be helpful? And the second thing is, I'm also the lead for what we call as PCRAF, which is basically making sure that the services to people with ethnic background also receive the same access, outcome, and experience. So I was just wondering, from your point of view, is there any thinking or thoughts already in place in terms of how we involve people with learning disability and their carers, even from these communities? Thank you.
Thank you. Thank you for those questions. For the first question, with supporting other services and mainstream services, I know our service does provide training if needed, and our experts by experience are always willing to go into other areas and provide training around learning disability awareness and any support with reasonable adjustments or communication needs. So that's definitely something that we can be involved with if other services want to contact us. As we said in the presentation, we have produced training for GP clinics and hospitals as well. So there's that aspect of it where we go in and support our acute liaison nurses and physical health nurses and provide training for nurses, doctors and nursing cadets, etc. The second question, we are involved also in community groups. So we do attend Voiceability, which is a community group within Voices for All, which is the Learning Disability Partnership Board. So we have that area that we're able to go and discuss and support. And also we're also open to attending any other groups that would like to meet us and for us to explain what we do within the roles of our experts by experience. I hope that's answered your question.
Yeah, thank you so much. Thank you.
You're welcome.
Thank you, Girish. Sarah.
Thank you. Morning, everybody. I'm Sarah Connery, Chief Executive here at the Trust, and thank you again, Tracy, for joining us and sharing that fabulous video. And I'm always blown away by the work that is going on with our EBEs. I haven't quite clocked the massive increase that we've seen from in terms of receiving feedback through opening up the different ways that work for people rather than what work for the Trust. I'm just wondering if there's any themes that have come out of that information into, I suppose it ties back to sort of Sharon and Kevin's point about what could we be doing better. So I know that's not the purpose of why you're here, but you'll know what we're getting right and what's coming through those themes. Thank you.
We are in the process of data collection, and Susie collects all the information from Envoy every time things are uploaded onto there and pops it onto a spreadsheet. And then what happens is, if there are any actions that are needed, she then forwards those to each hub for them to action any issues that have arose. And then what we do is then pop it into a newsletter and send out to the service users and the people who use our service. So from that point of view, we've not got to the stage where we're looking at themes yet, but that is definitely on the cards for this year. We're going to start really looking at what's happening in different areas and what if there's potentially the same things that are coming up in each area or with a specific discipline. So that's definitely on the to-do list this year. So we'll be back in touch, and we'll also be back in touch if we need your support.
Marvellous. Thank you, Tracy. Thank you.
You're welcome.
Thanks, Sarah. Amy, please.
Hi, Tracy. I'm Amy Beaton. I'm Chief People Officer here at the Trust. I just wanted to make a comment, really, because I was also blown away by the breadth in terms of the work, not only around onboarding experts by experience and then the pastoral care for them, but then also the breadth of the work that they're delivering. And, you know, I also know that yourself, and I think you said Susie, the amount of support and work that you're doing, a big thank you for that as well. You obviously mentioned a few teams that fall within my portfolio during the presentation around recruitment, and thank you for the comments you made around recruitment, but also mandatory training and staff wellbeing service. And so I was wondering if there was any, you know, further feedback you feel in terms of learning for any of those teams with experts by experience touching any of those services. And also whether experts by experience have been more involved, I suppose, in the proactive parts of those teams. So, you know, you described becoming involved with the teams because it wasn't right. But I'd be really interested if you're there before it goes wrong. So, for example, helping around policy work would be a key one.
Thank you. Yeah, I mean, for the first answer to your question, I mean, the end results were fantastic. You know, we were honest, our EBIEs were honest, especially regarding recruitment. We knew it wasn't working well with the lady last year, so we knew we had to step in and do something about it. And recruitment were you know, that they listened, they were fantastic, they were guided by us and the lady involved who gave her honest opinions about how it made her feel and what she would have preferred, what could have been improved. And yeah, and they absolutely listened and were fantastic, and we worked together and supported each other to provide information that future candidates would find a much easier process. The other service, oh gosh, I'm sorry, training, learning and development. We preempted that because we knew that our EBIEs wouldn't be able to access the online training, but we also knew that they had to fall within the realm of some sort of training that was relevant for their role for them in order for them to pass kind of the training. So we contacted learning and development and met with the leads in each service and worked together. At the time, we didn't have experts by experience when we first did this, so it was difficult to get their point of view. But once they were all employed, then they have been the centre of how the training is delivered. So at the moment we still do it face-to-face in Sleaford, and the fabulous leads all arrive and they provide the training throughout the day. We always give feedback on how it's gone. It's brilliantly pitched at a level that everybody understands. There's lots of opportunity for people to ask questions, and they're given corresponding easy read information in order to allow them to look at it later if they wanted to. So yeah, so working with those groups it's been a bit of a revelation, because as well it was the first time for us too. So to get together with different leads and work with them and support each other, it's been a really enjoyable process and a really positive process.
Thank you.
Thanks, Amy. I've got one more you'll be pleased to know, Tracy, which is Di.
Thanks, Kevin. Thanks, Tracy. I'm Di Bailey, one of the non-executive directors, and I just wanted to first of all echo all the comments from colleagues about how inspirational the presentation was. So thank you for that. I think what shone out for me was some really important messages about how you have made things very accessible in terms of the way that you talked about the way that people can give feedback, what you were just talking to Amy about in terms of the training. And I think we often overcomplicate things, just because of the kind of organisation that we are. So my question is a question to you, but I guess it's a question to the wider board, which is how can we take the principles that I think you've really explained so well for us today and make sure we apply them right across, not just for people in learning disability services, because if I think about me, some of the online training that I do, I don't feel is very accessible actually, and I think some of what you've done could benefit right across our services. So I think it's just a question about how we can take those principles and really make sure we apply them for the benefit of LPFT as a whole.
Thank you. Yeah, I mean, I think first of all, everybody needs to employ David Sheardown because he's the shining beacon of our accessible information standard, and he does not shut up about it across the service and outside of our service and trust. He's always been very passionate about people being understood and being able to understand, and I think that's the key thing, is that we need to make sure that everybody who accesses our service and the wider trust has that has that right to be understood and also to be able to understand what they're being told. I would advocate for every service user, every person who uses our trust and has accessed our services, to have a communication alert. In our learning disability service, this is part of our accessible information standard guidelines, and I do truly believe that we all have communication needs, and I think if everybody had a communication alert, that's a really good start. Regarding the training, I agree. It can be very complicated, but we get through it, don't we, at the end of the day? But yeah, I mean, maybe we do need to look as a trust, maybe we do need to look at a lot wider and think outside the box and look at how we are providing information.
Yeah, thank you. I think, yeah, thank you.
Thank you.
Thanks, Di. Tracy, because I'm chair, I get the last word, which is a privilege I enjoy very much. So first of all, I'd just say thank you very much for joining us this morning, and thank you for fielding those questions and comments so fantastically well. So thank you for that. And could you also pass on our sincere thanks to everybody involved in making the video, which is powerful and important. For me, I think the most important point out of all of this is if we're going to properly value the contribution that experts by experience can make, we need to make sure that we properly facilitate that and support them, and make sure that we can maximise the impact of their voice, not expect them to do it all for us. And you've spoken, I think, really compellingly this morning about how we can do that, and we just need to make sure that we do that consistently all the time. And probably not just, as Di has noted, with our experts by experience, but making sure that all of us properly understand what we're doing and why we're doing it. So there's some really important messages in that for us, Tracy. And you've also been made the offer that if you think as a board we could do things better to support the work that you do, please take that away as a genuine commitment on behalf of the board. And if you think we're getting it wrong, then come and bang on our door, virtually or really, and tell us.
Will do.
Thanks, Tracy. See you again.
Thank you so much for inviting me. Thank you. Bye-bye.
Bye now.
Thank you.
Right then, let's move on to our agenda for the rest of this meeting. Apologies for absence will be noted in the minutes. I know that there are a number of colleagues that have to dip in and out of the meeting during the course of this morning, and that's noted. Thank you very much. I should also say that I would like to welcome Helen Henderson to the meeting, who is our newly appointed next director or director on the next. Start again. Appointee on the next director scheme, but unfortunately Helen is having some technical difficulties. She's watching the meeting, but she can't be in it because there's a problem with her Teams apparently. So we'll wave to you from afar, Helen, and hopefully you'll be able to join us later. Helen is the Chief Executive of Healthwatch Derbyshire. I think she'll bring some excellent perspectives to our discussions as part of the Next Director programme. So really looking forward to working with you, Helen. If there are any declarations of interest, then moving on. If there are any that aren't as noted, then please shout. If there are none, we've got minutes of the Board of Directors meeting held on the 13th of February. I'd be grateful to hear from colleagues if there are any points of accuracy or other matters arising they wish to make or wish to draw to our attention. If there aren't, I'd be grateful for an indication if colleagues are happy for me to sign those minutes as a true record. Fabulous. So there's clear indication that you're happy for me to do so. So I will. Thank you very much. And we will move on then to the schedule of actions, which I'll take as read. There's one outstanding action, which is the continued development of the integrated performance report. There's a fairly full update there of where we are with that particular piece of work. But if anyone's got any questions or comments on the schedule of actions, then please let me know and we'll take those. If not, then we'll move on to the next item, which is remarks from the chair. The only thing I was going to mention was Helen's appointment. I haven't got anything else substantive that wouldn't significantly overlap with the report that the Chief Executive, I shall invite the Chief Executive to make momentarily. But if there, so I haven't got anything to add to that, so I will hand over then to Sarah for the Chief Executive's report. Sarah.
Thank you, Chair. So Sarah Connery, Chief Executive of LPFT, here with my usual Chief Executive's report. I will assume the paper is read and hopefully colleagues found the information accessible, but I will hone in this month around the 2025 and 2026 planning round and also recent national announcements about NHS architecture and infrastructure, and then allow some time for comments and questions, which I think could be sort of more helpful given the fast-paced nature of how a lot of the information is coming through. So there is reference there, and I would urge colleagues to read the proposed new NHS performance assessment framework. And we have discussed this before at board around upcoming changes, but obviously the nature of the framework will be driven a lot by what the actual architecture is around it. So they're kind of hand in glove, but moving at pace quite quickly in terms of we are in local election period as well. So there will be a full sort of public consultation between the 2nd of May and the 23rd of May. So it will be quite a short period in terms of time to engage. So please, colleagues, do have a read of that in terms of what that will mean for the board, what we've got our eye on in terms of which segment that we're in, what level of oversight we're receiving from whoever is overseeing our performance, and also what targets that we're looking at. And as you've mentioned, Kevin, we have been doing a lot of work in the background around what our balanced scorecard will look like in the future. But there are changes that are being proposed that would impact on that. So we're having to move forward carefully in terms of making sure that we don't have to unpick things once that consultation is complete. But in terms of national announcements, so myself and Kevin were invited to attend a sort of national leadership event down in London on the 13th of March, where announcements were made about NHS England as an organisation being integrated into the Department of Health and Social Care within 2 years. Integrated care boards really expected to reduce their running costs quite significantly by Q3 this year, and provide a trust similarly expected to reduce the cost of non-patient facing corporate services by Q3 of this year. Also provide a trust being asked to look at outsourcing some support services as well, and discussions around wholly owned subsidiary. So new sort of guidance around what this means is coming out literally on a daily basis. So please do bear with us while we sort of work through what all of that means. We have now had sort of a target given to us around reduction in non-patient facing roles, so we're working through that. Clearly this is a very challenging time for the NHS nationally and locally. But what we need to do is remember that we've still got patients coming through the front door every day who need our care and support. So we must stay focused on that. We're working really closely with staff side as we move through what the implications are of all of this for our very valued staff and teams. We also want to make sure that we're regularly and honestly communicating with all of our staff. So we are putting in more frequent touch points with the executive team where people can ask questions and raise challenges to us on a more frequent basis than we've had previously. So watch this space, but we'll keep the board appraised, obviously, when we know more around this. I think tied into this is the very challenging 2025-26 planning round. Something that I'm really proud of is that the Trust was able to submit a plan that shows that we will be meeting all of our performance targets for next year. We have committed to safe staffing, so in terms of the workforce changes, they're really bottom up in terms of how they've been built, and they triangulate really well with activity and finance. What that does mean is we are proposing that we will be in a financial deficit at the end of 25-26 of 3.7 million. Now, we obviously have accountability to the communities that we serve, but we also have accountability to the taxpayer, and we're proposing a quite tight and focused programme of work called Living Within Our Means, which we'll be discussing in part 2 of the board. Because there are some decisions to be made around the governance of that programme of work, led by our Chief Finance Officer, Mark Platts, but with a role for all of our executive team in terms of leading up certain pieces of work. I think something that is quite interesting through this work is mental health now really coming under the radar in terms of productivity and efficiency. And I think there's a conversation that we need to have as a board at potentially our next board development session around what that means for us. Where do we feel we have red lines around what our services look like and how we're still able to achieve our trust strategy? I think Tracy's presentation just now shows that the equation around productivity might not actually work in its sort of purest sense if we're talking about reasonable adjustments, recruiting people with lived experience. What we need to keep focused on is the outcomes that we're achieving through our resource. And again, that's something that we need to attend to here in LPFT, and is part of our trust strategy, that we get better about understanding what is the impact on outcomes of the resources and how we arrange our services. So I think it's been a very challenging planning round. I want to thank all of the people who are involved in getting to what I feel is a very well triangulated and not without risk but delivery plan, and particularly the executive team who have been working their socks off in making sure that we've got to that position. I do also want to just point out quickly really fabulous results in terms of our staff survey, where we have been sort of we are top in the country for a number of the people promise pillars. which is really positive. Not that we don't have more to do. We've got an ambition to do better and learn from other trusts that are sort of doing better than us on some of those frames. I also want to say we had a really positive relationship meeting with our CQC inspectors and leads this week. Myself and Kevin and Sharon and Eve all having a really good conversation about what some of our challenges are here at the Trust, but also what we're really proud of. And you'll see that we have retained good rating in our community mental health services following the last inspection. Also, just want to say, end on a high. We were double winner at the Lincolnshire Care Awards for our co-production work with the Every Voice group and the Building Together group. So, you know, fantastic news. And again, reflects our ambition as a trust to make sure that we're doing things the right way as well as doing the right things, if that makes sense. So I'll stop there, Kevin, and I'm really happy to take any comments or questions.
Thanks, Sarah. Just an initial comment from me, and that's, you know, to note on behalf of the board how much work went into developing the LPFT plan for 2025-26 and how challenging it's been for the exec team, both in terms of time and the way that you've had to think some difficult thoughts and take some difficult decisions, you know, all of which have been endorsed separately by the board in signing off the submission of the plan. But just, you know, in this public meeting, just want to acknowledge on behalf of the board, you know, the tricky, time-consuming and you know, tiring work that's gone into that. So, you know, gratitude on behalf of the board for all of that. Thank you. I'll take some questions and comments. Tim.
Thank you, Kevin. Tim Harry, Non-Exec Director. Thank you, Sarah. As ever, a rich and informative and thoughtful report. One comment and one question. Comment is really pleased to see the development around the staff wellbeing offer and the move towards intervention and prevention and support during incidents, which we know, you know, we're always striving to do better in those areas. So that's really great. The other one is a bit of detail, but I wondered if you could just sort of clarify at the NHS leadership event and the provided trust outsourcing some support services. Was the direction around that outsourcing outside the NHS, or does that include outsourcing from your own provider to maybe a collaborative arrangement with other provider trusts? Did it go into that sort of detail?
No, it didn't, and I'm not sure whether there will be any more guidance coming out around that particular one. I think the key point that was being made was come at things from a different perspective and maybe sort of come out of your mental valleys around how you are delivering some of these services. And, you know, the interim chief executive of NHS England is his trust has been at the forefront of some of this in terms of thinking about things differently, leaning into different supply chains to not just deliver better value for money, but, you know, improve quality at the end of the day as well. So there's lots to work through there.
Yeah.
You know, we need to think about our partnerships in the East Midlands Alliance, as well as in Lincolnshire, as well as regionally. So I think, you know, really trying to see it as a bit of an opportunity to think differently. We've got our Foundation Trust badge. What does that mean? You know, we do have a healthy cash position at present. What else can we do with that? We've talked about that as a board before. Are there any options around what we could do through different delivery vehicles? I think into a wholly owned subsidiary just being one, if I'm being completely honest, it was just one that was sort of thrown in there. So yeah, trying to keep the juices flowing in terms of thinking about this as an opportunity rather than something that ultimately is just about cutting to save money, because I think there is a lot of opportunity in here, particularly around our target operating model and some of the ambition in that.
Yeah, thank you.
Thanks, Tim. Sarah. Oh, no. An indication from Sarah Whiteman that she wanted to ask a question, but I think your question's been answered, Sarah. Is that right?
Thank you, Chair.
Yeah, I'm grateful. Thank you, Ian.
Thanks, Chair, and thanks for the report and presentation, Sarah. Really informative. The one bit I just wanted to touch on, if I may, is the reference you made to the recent note from the new Chief Exec of NHS England. And I, in particular, was looking at the detail and the tables behind the scenes there, and I just wondered. I was struggling to understand it, and in particular this point about distance from target in terms of some of the figures that have been set. But my overriding question, I guess, is that is there anything in there that are particular threats or opportunities to Lincolnshire as a system?
Yeah, that's a good question, Ian, because our distance from target, so just so that colleagues are aware, this is where the funding formula, which is a kind of national funding formula, and it's weighted and really complex, but ultimately it gives an idea of the allocation that you should have per system versus what your historical allocation was. Now, any changes to allocations needs to be done in a sort of safe and planned way, but some systems are receiving more money than their allocation would, the funding formula would indicate, and some are receiving less. Lincolnshire is just about right, so we're kind of smack bang in the middle. I don't know whether we would want to take that as a positive or not. I think there is something about how the funding formula works around rurality, for example. So we'll keep conversations going with our local authority colleagues and our police colleagues, etc., around, you know, what does look like a fair funding formula for Lincolnshire. But as we keep hearing, the money is the money, and we have to make sure that we're doing everything that we can within that. So I hope that answers the question, but we are steadily working through it all, and sort of fresh information coming out sort of literally on a day-by-day basis that we're still sort of working through.
It's helpful, thank you.
Thank you.
Thanks, Ian. Thank you, Sarah, for as I think Tim said, a typically full and helpful report. I think the overriding comment from me is that there's an awful lot of turbulence, both, you know, kind of locally and nationally. That's a trite point, you know, it's obvious, but we need to make sure, both as a board and as a management team, that we don't take our eye off the operational ball, as it were. You know, it's very easy to do when there's a lot going on. So I think we just need to make sure that we redouble our efforts not to do that. And I'm not suggesting for a moment that that's what's happening, but we just need to be, I think, as a board, collectively alive to that risk.
Yeah, absolutely. Thank you.
Let's move on then, shall we, to item 2.2, which is the operational risk register. Karen.
Thank you, Kevin. Good morning, everybody. I'm Karen Scott. I'm Trust Secretary at LPFT. I'm going to take the paper as read and hope it's quite self-explanatory, but just want to draw the board's attention to a couple of areas specifically, and also draw attention to the list of bullet points within the recommendation section, because there are a number of proposals being made within this paper for the board to consider and make a decision on moving forward. So in summary, really, there's lots of work being going on within the organisation over the last few months regarding the reporting and management of risk within the Trust. And that's led to a number of changes being made within the Trust policy regarding the reporting and management of risk. Those have previously been discussed and thoroughly scrutinised by the Audit and Risk Committee, and the board has been cited on those. So we've also, aligned to that, been making some refinements to the way in which we present risks on the organisational risk register, and there's been alignment of all of the risks to the 4 pillars within the Trust's overarching strategy. And one of the proposals that I'm asking the board to consider approving this morning is that moving forward, now that we have actually made that very much closer alignment to those pillars, which actually each of the board's committees do have a respective section within the board assurance framework for, that we actually report on the detail of the risks relative to each of those committees to them at each of their meetings, and rather than the board getting that level of specific detail, seems much more appropriate that the committees consider that, and that thereon that will go through with the entire board assurance framework to the Audit and Risk Committee. So the suggestion is that the board delegates authority to the Audit and Risk Committee for overall scrutiny and decision making regarding the organisational risk register, and that any specific concerns that the committee may have, that it actually draws to the board's attention via its highlights and exceptions report moving forward. The second area for consideration this morning is actually that by doing that, currently the board of directors has overall responsibility for making decisions about closure of risks on the organisational risk register. So given the previous recommendation, it's proposed that the Audit and Risk Committee is delegated authority to make those decisions moving forward. And again, that the board is cited on that via that highlights and exceptions report, or if the committee feels that it warrants more detailed discussion by the board, then that can obviously happen. So I think that summarises it, I hope. And so, yes, just asking that the board considers those two recommendations specifically. Thank you, Kevin. Happy to take any questions.
Thank you very much, Karen. I think these are really important proposed changes for two reasons. Firstly, it enables the board to focus properly on the risks that the board needs to be focused on, that is those that that represent significant corporate risk, and also because it just underlines the role of the Audit and Risk Committee, and emphasises the role of that committee in providing the board with assurance around our risk management processes and ensuring that the board is indeed focused on the key corporate risks. So I think these are really important and welcome changes. So thank you very much for that, Karen. I don't see any questions or comments from colleagues. So can I invite colleagues, please, to indicate if they're content to approve these proposed changes. And the answer to that is yes. So thank you very much, Karen. Thanks for a really clear and helpful report and for presenting it in the way that you did. I'm grateful. Thank you.
Thank you, Kevin.
We'll move on then to item 5.1, which is a highlight and exception report from the Performance Committee held on the 27th of March. Di.
Thanks, Kevin. Just a couple of comments from me, in addition to the information contained in the paper, just to kind of link the highlights and exceptions report to what's been said elsewhere in this meeting, really. So Sarah has already mentioned the proposed NHS performance assessment framework changing. And one of the things that we discussed at Performance Committee within the context of that conversation about the balanced scorecard was that while we've identified a number of measures that we look at in Performance Committee in terms of the different pillars of the trust strategy, they may need to be adapted, at least over the 25-26 period, to reflect that wider performance assessment framework once we understand that in a bit more detail. So I just wanted to mention that to give a sense that we are taking account really of that wider context in the way that we judge performance within LPFT. We've also mentioned already in this meeting, you know, again, in the external context, the importance of doing things differently and some of that blue sky thinking that we might need, particularly to balance the kind of resources and resource challenges that we have in that context of productivity. And one of the things that we discussed in detail in Performance Committee was about the weights in relation to young people's services. And I think we received assurance from the Chief Operating Officer that, you know, we won't shift the dial on young people's weights if we continue to do things like we've always done it. So we really heard that we need to, you know, we need to think outside the box on this, and we were assured that that was happening, and that it will come back to Performance Committee at some point to be determined as appropriate. And then finally, I think we gained real insight into our length of stay data by including in that data not just the lengths of stay for people in our inpatient wards, but for people going through our psychiatric clinical decisions unit, the PCDU. And that was really important for us to understand and look to in terms of how we judge our performance around that length of stay data going forward. So yeah, I'll stop there. I'm happy to take any questions or comments.
Thanks very much, Di. Questions or comments? Sarah Whiteman.
Thank you. Hello, Sarah Whiteman, Non-Executive Director. I just wanted to say that I think it was a really good meeting, that one, Di, and it was very well chaired. And it was, what I found particularly useful was the continual cross-referencing with the other committees. So, for example, we talked about some issues relating, as Di said, about children and young people, but also older adults with severe mental illness being admitted to dementia wards and things like that. Yeah. So raising issues that cut across to quality, also best use of resources. And I think that's a really strong development that's happening since Di has taken over as the Performance Committee, and I find it really useful.
Thanks, Sarah. That's I think a really important comment, Di, isn't it? Because you know the reason that we created the Performance Committee was to do exactly that kind of triangulation, and so I think, you know, for the board, it's reassuring that that's exactly what the committee's doing.
It is, Kevin. I think we've got more to do. Sure. In that space, particularly in the light of that whole productivity agenda. So I thank Sarah for her comments, and as chair, I will, you know, I will continue to be. You know, I'm pleased with the comments, but obviously I'm not going to be complacent, and I think there is more that we can do in that space. But yes, it's certainly evolved, and I think you know, we've mentioned the balanced scorecard already, and you alluded to it, Kevin, earlier in the actions at the start of the meeting, and we did have a further discussion about the balanced scorecard, and I think that will ultimately impact on that cross-committee relationship as well, once we start to look at the metrics that come into the balanced scorecard, because inevitably, whilst in Performance Committee we will look at them through a performance lens, those metrics will reflect what we're doing in the sphere of quality of people and best use of resources as well.
Excellent, thanks, Di. Eve.
Thank you, Kevin. Eve Baird, Chief Operating Officer. I just wanted to comment, really, the Performance Committee feels like a really important committee, and we're discussing the right things. I think one of the reasons we're able to do that is because of the quality of the data that we're getting now, and it was something that we reflected when we met with the CQC earlier this week, that the quality of the data that we're getting around what's happening in our services, how that data is being analysed, how it's made accessible to at different levels of the organisation for us to really use it to understand what's happening and how we can improve things, I think is making a significant difference to how we think about performance. And so I just wanted to acknowledge that, because I don't think the Performance Committee would be as successful if we didn't have the richness of data that we've got coming through.
Yeah, understood. I think that's a really important observation, Eve. Thank you. Thank you very much, Di. Thank you for your continued chairing of the performance committee, and I think as a board we look forward to it developing further. So thank you very much for that. We'll move on then, if we may, to item 5.2, which is the integrated performance report. Mark.
Good morning, Chair, and morning, everyone. So I'm Mark Platts, I'm the Chief Finance Officer, and I'm here today to kind of talk through our integrated performance report. So I'm probably going to start with some important headlines to note. Positive start. Our virtual autism hub has been up and running live now for just over 12 months, and we've already supported over 700 interactions with patients, which is starting to make a real difference. So some really positive work there. As Sarah's mentioned within her report as well, it's important, given the challenges that we're facing in the NHS, that we continue to adapt and evolve. So we've also reported that we have replaced and streamlined our helpline services, moving all our services, to the majority of our services, to the NHS 111 option 2. This is all about making it as easy as possible for patients to access our service. Another area of vital importance is we continue to support our staff. So with everything that's going on within our services, the wider NHS at the minute, it's very challenging times. And whilst there's a positive that sickness has reduced, we continue to see that the main reasons for our sickness for our staff is anxiety, stress and depression. So we really need to work hard to support that where we can. And we've touched on the staff wellbeing offer in previous discussions. So some work to support of our staff there. So just picking up on some of the highlights of what's going well. So as a partnership trust, it's important we continue to improve our partnership working with us across the system. So we've done that within Lincolnshire across a number of services, and one report within our report this month is around our criminal justice and liaison service. So some great work there, improving our offer to our patients. However, where we do need to improve, we are proving to do so. So we've had recent discussions with CQC following a visit to our Boston Spalding mental health team. And that recent visit was assessed as the service being good and performing well. And that was despite being built on potential concerns that were raised previously. So some great work by the team there to improve where we do find we need to. And another positive, which I think is really strong given the challenges faced by our services at the minute, is our increased supervision rates. So particularly important to highlight our adult inpatient urgent care division and our older people and frailty services. So supervision is a really important way of supporting our staff to understand how we can provide the best care to the patients that we have within our services. So great to see those levels of supervision increasing across our services. It wouldn't be an integrated performance report without mentioning a couple of challenges that we are facing as a trust. And the first one I'm just going to touch on is physical healthcare monitoring. So we need to look at how we work with our primary care partners across the system to improve the level of monitoring, to make sure that we can get the vital health, physical health statistics of our patients as visible as possible, so we can really focus on the care and understand where we're looking at. There are some particular areas of concern at the minute, particularly around ECG and blood tests, but that's something I know our service teams are working hard to improve the levels of monitoring. Child and adolescent mental health services treatment waits. So this is an area that we've discussed many times as a board, and this time last year we set ourselves a target to ensure that we had no young people waiting longer than 12 weeks for treatment. On the back of that commitment, a lot of work has gone into our services to develop and refine where we can, and significant improvements have been made, which means that Lincolnshire is now one of the lowest wait times across the region. However, this is not as low as we want it to be, and there is some strong work continuing to help to develop and improve on our target on that one. Out of area placements, another area of consistent challenge for the organisation is still there. So at the minute, within March, the reporting of the data within the report, we did have 8 patients that were sadly placed out of area. But again, looking at this, we're working at new innovative ways, working with our local integrated care boards to pilot new services to ensure that we can get as many patients treated as close to home as possible. In terms of access reporting, so the main metrics within the report are reported within there, and they're kind of consistent with a lot of the themes that I just talked about within the CYP areas. Obviously, it's essential that we maximise access to our services. That's got to be a key focus for us. But another area, which Eve's just kindly linked to, which our reference is, we've got to make sure we get our data right so that we know where we are offering that service, that we can report on that as best we can. So data accuracy is really important to make sure we focus on the areas that really needs focusing. So a lot of work continuing to look at improving our data and understanding of our weight performance across all of our services. And another area that is helping potentially with our access across services, we are seeing a reduced vacancy rate and staff turnover. So the theory behind that is hopefully we're helping to stabilise our services as much as possible, improving wait times where we can. In terms of experience, we're continuing to evolve and develop this report, and one new key metric that's come into this report this month is we're now making use of our friends and family test, and we're now looking at reporting the percentage of patients surveyed that note their recent experience is either good or very good, and that's standing at 92%. So some really positive news there from that feedback. However, it's important we look at our metrics around this so we can broaden them to be as representative of all of our services as we can, but some great work by our team to move forward on that one. We're also looking at how we can move and collect patient feedback on that. So we're continuing to work with our patients to understand where we can get feedback where possible. In terms of quality, so we're working on our quality areas. So some key areas, our complaints policy has been revised and published, so approved by the quality committee. So great to see the improvements within that, so we can understand where we're not quite getting things right, how we can remedy that and move it forward. And some great work noted by the Francis Willis unit coming towards the end of their culture of care program around a lot of the My Life booklets and a lot of the work that the team are doing there as well. So great to see that. And the staff safety project, that's something that's continuing to ongo, so we can look at how we can support post-incident and prevent, and also in reports moving forward as well. So some really important work streams around our quality focus moving forward on that one. In terms of patient outcomes, so we are looking at the best way of reporting a lot of the outcomes, and there's a bit of an update in the report of the work that's being done there around the tracking progress and resource allocations and how we can move forward with that one. So we'll continue to look at bringing metrics in where we can on that. But as Sarah said, recent changes around reporting that are going through consultation may impact on how we bring some of these to life through public board moving forward, but we'll be transparent as ever and show the information as we can. In terms of our best use of resources, so from a finance viewpoint, we are currently forecasting to meet our slightly revised year-end trajectory. So the finance team are working on that this week. So we'll have that finalised figure shortly to be reported to board, but some significant evidence of the grip and control that we have as an organisation around our financial performance. So a massive thank you to everyone who's doing all we can to meet the financial challenges in what is a very, very difficult time for the NHS at the minute. Pleased to say, and it's good that a number of our colleagues have been able to go over and visit recently, but in terms of our capital expenditure, great work is continuing on our Norton Lee site. So Havenside Ward and Norton T are coming along nicely. So the building's on track and looking to be completed across the timeframes next year, and that's a significant part of our capital investment at £25 million for this financial year. So I'm going to leave it there, Chair, if that's okay, and happy to take any questions on the document or any of the metrics for a minute.
Thank you very much, Mark. Thanks for an excellent report and for providing those additional comments in introducing it. Thank you very much. Tim.
Hi, thanks, Kevin. Yeah, Tim Harry, non-exec director. Yeah, Mark, thanks for the report, and it's really good to see the continuing development of it. We know there's more to come in that, but you know, it's really shaping up, I think. My one comment was I thought how good the patient experience result was, which I think we must benchmark pretty well on that. And I know we'll never be complacent about that area, but you know, it's good to see progress like that and getting that sort of data. And my question related to the physical health support, and there was a question in there whether the challenge we were facing in that area was either because of the action being taken or whether it was part of what was the longer term direction in that. But I wondered if we got clarity in our minds about how we are going to provide that physical health support check around blood tests and ECGs, etc. Because the way I was reading it is something that it looks like we're going to have to bring in-house or have another option.
Yeah, thanks, Tim. It's an important question. Certainly on some of the exec visits that I've been out, and I have sort of spoken to teams who are trying to look at that. But I suppose as an organisation, we've got to make sure we focus on the key areas that we're commissioned to and get the right sort of system partners to working as we need to. But I've noticed Eve is able to come in on that one. So if I can hand over to Eve, that'd be great.
Thanks, Mark. Eve Baird, Chief Operating Officer. It's something we're working really hard across primary care and our colleagues in community health services to look at what's already commissioned in Lincolnshire and how we might tap into that, because what we're really clear on is our mental health patients should be able to access mainstream physical healthcare services, and what we don't want to be doing is excluding people from those services because they have a mental health diagnosis. So we're working at the moment with colleagues in primary care and also colleagues in the new CDCs, the community diagnostic centres, to look at how we might access that support. Obviously, if we need to, we will look at what we can do internally. But that will then take away a resource elsewhere. So that needs to be, for me, that needs to be our last resort. And actually, we need to be looking at what we can do to support our colleagues who already work in physical healthcare services to feel confident to be able to do some of the tests and things that we're asking for, with support from our colleagues to interpret that in the context of the mental health condition, whether that's an eating disorder or schizophrenia. So there's a lot of work going on in that space, but it does feel like it's an ever-changing space at the moment.
Thanks, Eve. That makes perfect sense what you just said, and it was those sort of Thank you.
Thanks, Tim. Di.
Thanks, Kevin. Di Bailey, non-exec director. Thank you, Mark, for the report. I was just reflecting, actually, as you were talking, particularly reflecting on the patient experience data that we're now getting through. And I think it picks up Eve's point that she made earlier when we were talking about the highlights and exceptions report from Performance Committee. I think with that increase in the quality of data that we're getting, I think that should give us some increased opportunities for looking for correlations, patterns within our data. So, I'm really interested in understanding how that patient experience measure correlates with some of our measures around staff experience, for example, and also patient safety experience and the data that we have about bank and agency staffing and those kind of things. So I think I think there are real opportunities here going forward, and I think I look forward to having some of those future conversations within Performance Committee about how we can, if you like, get better intelligence and insights as that data maturity comes through. So thank you.
Thanks, Di. I think the important point to note off off the back of your comment and more generally, is that we are continuing to develop the way in which we report and consider performance as data quality improves, the range of data that we've got available improves, and the role of the performance committee, development of the balanced scorecard, and so on. And I think the board should take some assurance from that in terms of the fact that we are not simply reporting a set of metrics and that's the end of it. We are as an organisation taking considerable care and investing considerable time and effort into making sure that the board has real insight to get to grips with, rather than just metrics, and that's all part of that process. So welcome that very much. Sarah Whiteman.
Thank you. Yes, Sarah Whiteman, GP by background as well as a non-exec director. Just leading on from something that Eve said about primary care and working with partners, I wondered what impact GP collective action has had on the work of the trust and where we are with that. So for people who don't know, GP collective action is pretty much GPs almost working to rule and not outside their contract, and that's in the interests of sustainability of general practice really, but has knock-on effects for trusts, including ours.
Yeah, great question. Thanks, Sarah. And I have noticed I've got Eve and Girish coming on that one. So
yeah,
if I can...
I was going to point that out to you, Mark. So yeah.
Thank you.
So Eve, do you want to go first?
Thanks, Mark. Yes, just to say we're monitoring the impact of GP collective action. What's difficult about monitoring it is that because GP practices are independent practices, we do see different pathways with different GP practices anyway, and therefore understanding what's a direct result of the GP collective action versus what's actually the result of different pathways and different preferred ways of working across different GP surgeries is difficult, but we are monitoring that, and any where we can make a direct correlation to the GP collective action. In some cases we can, because we get letters from GPs saying we're not prepared to do this because of collective action. We're collating all that information, and then that's being fed up through Girish, who I believe wants to come in as well.
Thanks, Steve. Girish, do you want to add anything to that?
Yeah, thank you. I'm Dr. Girish Kunigiri, the Chief Medical Officer. A couple of things here. One is LPFT has drawn a new guidance based on prescribing as well as physical health examination between primary care and secondary care, which has gone through different layers within our organization as well as within ICB, and it has been more or less signed off, which is in line with the new guidance which will be released nationally on interface between primary and secondary care. The problem is that in any of these documents, we need to acknowledge two things. One is there is a commissioning gap in Lincolnshire in terms of who actually manages these patients with regard to physical health and SMI, because the national guidance is that in the first 1 year, the responsibility for patients who are on specific medications lies with secondary care, and then it goes to the primary care. However, it doesn't take into account many other patients with mental illness who are not specifically on certain medications. The second thing is there is a lot of goodwill between primary care and secondary care in terms of managing these patients. So, and the third is there are also some data issues that the measurements what we do in secondary care is not necessarily on the primary care system, so that when the data is pulled across the ICS, there has been issues. So in terms of what we are doing, also with what Eve was talking about in terms of how we have collated all the information, we are having series of conversations with our primary care, and we are trying to align, some of the pathways what Eve was talking about, so that there is some consensus and we have a mutual agreement in terms of what constitutes goodwill and what needs to be prepared. And at the same time, we are also doing some mapping exercise in terms of as he was saying, looking at where we have the services and how our patients can be facilitated to use those services rather than being, moved to different places to receive their physical health care. Sorry, does that help, Sarah? Thank you.
Really good answer. Thank you.
Thanks, Sarah. Amy.
Yeah, thank you. I just wanted to make a comment because I'm cognizant of the fact that sickness has been raised both in the Performance Committee Highlight and Exception Report and in the IPR. And obviously Mark's referenced some of the work that's been going on with staff wellbeing service in that space. And we've also been looking at better reporting and driving accountability for policy adherence through our team. So whilst this IPR obviously refers to January 2025 data, I can just confirm and just provide a bit more assurance to board that as at the end of March, our sickness has come down by a further % approximately. So I just wanted to share that note in the comments that's been raised around sickness in the report.
Thanks, Amy. That's helpful. A couple of comments from me, Mark. One general and one very, very specific. The general point is to repeat what I've already said, really, which is, the way that the IPR has developed has been really positive, and what you've presented us with this morning is a really helpful report. So thank you for that, and thank you for the contributions from others. My question is a really specific one, and it's about the Criminal Justice Diversion and Liaison Service and the expansion to home visits by Lincolnshire Action Trust. It's my understanding that was always part of the contract, but we weren't delivering it. So although it's an expansion, it's an expansion to deliver the original terms of the contract. Am I right on that?
Yeah, that's correct.
Okay, that's great. I'm not wishing to downplay the fact that it's an expansion in service, and I'm glad that we're doing it. Good. Thanks, Mark. Thank you very much for that. If colleagues are happy, we'll move on to what I think is the final substantive item on the agenda, which is target operating model. Chris.
Yeah, thank you, Chair. So Chris Higgins, Chief Transformation Officer, and I'm pleased to be presenting the target operating model, not least because it's the product of quite a number of months, a number of inputs from Board of Directors, Council Governors, senior leadership team in the organisation, and taking the report as read, but just to highlight a few bits. This has been produced in the context of a few things. One is our own trust strategy and our ambitions within that, the changing environment in the local system, and the new direction of travel for the NHS around things that Sarah's previously spoke around in terms of hospital to community, sickness to prevention and things. And so really setting out our ambition as an organisation, our intention to step into a space where we take greater responsibility for the whole population's mental health and well-being. So no longer just focusing on the provision of direct health care for mental health and other specialist services, but also to address those wider determinants of health, which we know that it's those both things combined that really make a difference to people's lives. And so the target operating model signals that and sets out our 2 areas of operational focus as described in the paper around that direct clinical care. And what I would say on that is we won't take our eye off the ball on that. That is absolutely central to who we are as an organisation and part of our identity as a specialist provider. But we also need to attend to those wider determinants of health that we know are important, like housing, like employment, like social networks. And we've done some work in that space, but there's much more to do. The paper itself has been through the board development sessions. It's been to a joint board with the council governors and will be presented to council governors in due course, and has been through our senior leadership team on the 1st of April, who reviewed it in detail and have recommended approval to the board. What I would say in terms of, if I come to the approval part, is just in terms of next steps, if it's approved today,
the intention is then to develop a long-term operational plan that really define the actual activities that we're going to take to improve our clinical offer of specialist services, but also the other things that we're going to do around working in partnership, potentially contract with others, and providing ourselves things that will address those wider determinants of health, help people into employment, help people to access the appropriate accommodation that they need, and other things. So, but we need a plan around that. So we're going to develop that over the coming months, based on a period of engagement. So we will be inviting people to get involved in that piece of work, to agree what we need to do, what things we need to put in place, and how we might prioritise those things. But that'll culminate in a long-term operational plan underpinned by a financial model that will be able to demonstrate how we maintain financial stability whilst moving into some of these new areas of development. It's here for approval, and I just want to make two points around the approval that I'm asking for. One is to approve the target operating model itself and what we're intending to do. The other really aligns to our risk appetite as a board, and you'll see in the end section there that the old and current, so I know we're in this interim phase on our risk appetite, it probably is more ambitious than what our previous risk appetite set out. However, based on the new risk appetite that the board's been working to, and we're now just about to launch, I believe it does align to what our ambitions around risk. And I think it's just important in the context of approving the target operating model. We're not just approving a document and a set of words, we're also approving to adopt a different organisational mindset that means that we're prepared to take risk and take opportunity with that, and we're prepared to fail at some things, but when we fail, we'll fail quickly, learn quickly, and we'll move on. But I think there's something about recognising that if we don't adopt that new mindset and really hold true to our risk appetite, then this could take much longer to progress or not progress at all. So it's, whilst I'm asking for approval of the document, it's also in the context of that appetite for risk at the same time.
Thank you very much, Chris. I was going to make exactly the same point, and this is not just about signing off a document, it's about signing off and adhering to a different way of working, and one which, going back to the Chief Executive's report, with all of the turbulence in the system, the challenges of planning and whatever, all of this becomes even more important than it was when we embarked on this process. And before I bring in a couple of colleagues who've got comments, also to reinforce the fact that none of what's in the paper should be new to any of us. As you've said, Chris, this has gone through a number of phases and iterations. We've seen it as a board more than once. It's been poured over in the target operating model program board. So this has had several coats of looking at. So there's nothing in here I don't think that should come as a surprise or a shock to anybody. But a couple of comments. I think I've got Di first.
Thanks, Kevin. Thanks, Chris. Absolutely, I agree with everything that Kevin's just said, really. I think this is a culmination of work that we have had on the board agenda since the introduction of the strategy, really. And one thing I just wanted to urge us to do is to, because I think some of the thinking has already been done, as evidenced by those strategic plans that were drawn up across the different pillars of the strategy and within the different service lines that we have. And I would just really urge us to, to be kind to ourselves, particularly in the light of other work that we've got to do, and some things we will have to stand down in order to do it, that we draw from what we've already done rather than set about doing things again. And I think that's equally important, given Sarah's comments earlier about the other programme of work that's on our horizon around the living within our means. So I think I just wanted to really stress that we need to look for synergies and using what we've done already rather than reinventing the wheel. Thank you.
Thanks, Di. Tim.
Thanks, Kevin. So Tim Harry, Non-Exec Director. Yeah, first of all, I thought it was a really good paper. I thought it was great, actually, because it has really pulled together all those conversations we had, and I thought set it out really well. I I think following on a little bit from what Di was saying, because it is ambitious, you know, I don't think we could be any more ambitious than this, and but I fully support that. But as I think I've probably said on occasions, I think it's going to be in the detail of how we prioritise, because it is so broad and so on, that to make it successful, we've really got to be sort of careful around that, and in our approach, as Di said, sort of building on what we've already done rather than trying to reinvent stuff. I think one of my other sort of hobby horses is I think there is probably an opportunity to look at organisational design from its broadest perspective, you know, whether it's sort of culture, etc., to support the new organisation that we will be under this. And then the final comment really is a little bit of sort of detail, and I haven't thought it all the way through, but on page 12 in the paper, there's a nice diagram, and it talks about the strategic objectives and so on. I'm just working my way through thinking about that, whether we need to have another think about some of the strategic objectives that we've already agreed under our new strategy, and whether there are some other facets that we need to include in there. Now we've got the broader determinants in particular. Thank you.
Happy to coming back on that, and thank you, Tim.
Please,
absolutely, really helpful. I think you're right in terms of the strategy. I think there's just something about these things are iterative. The strategy was written at a moment in time, and I think it still holds true in terms of the objectives. But there's a bit about going into the detail of that to understand whether it still holds true, given the operating environment in which we're working has changed, and given that we've got much clearer, I think, in terms of our intent and ambitions. So I think there is an opportunity to revisit that as a board and see if it still holds true, or whether we need to make some adjustments.
Thanks, Chris. Thanks, Tim. Sarah.
Yeah, thank you. I think some of the comments and questions from the non-executive directors are really mirroring what we discussed as an exec team yesterday around the strategy, around the length of the strategy, what's affordable and not affordable now, if we're being completely honest, what we need to ramp up and what we need to slow down in order to make sure that we're living within our means, as well as attending to what we're trying to achieve in the target operating model. So I just wanted to share that, really, that it's very much in line with the conversations that we've been having as executive team. But just want to reiterate again, it's a brilliant document, and while we're talking about an awful lot about finances at the minute, it's just great just to stop and pause and think about what LPFT has actually achieved over the past sort of 10 years. But you know, we've got ambition to go further, so it's just want to say a big thank you to Chris for pulling it together. Thank you.
Thanks, Sarah. I mean, I think, you know, given this programme of work, and later on in private board we'll talk about potentially a new programme around financial sustainability, it would be it's inevitable that we will want to circle back and revisit the strategy, because, you know, both of those programs post-date the development of a strategy that you know, has to be re-looked at in the context of where we land with both of those programs. So I think that's both, you know, kind of natural and to be expected. So we need to keep that in mind. So, Chris, you need formal approval from the board for this document. So can I ask colleagues, please, to indicate whether or not they are content to agree it? But there's a clear consensus. Yes, Sarah's so keen on it that she said yes 3 times. So very good, an excellent paper, Chris. And you know, just to echo what others have said, you know, really impressive piece of work putting all of this together, and you know, going through all the stages that it has. So thank you very much. The last item then we have remaining on the board is the forthcoming programme. Karen, I don't know whether there's anything you want to add, or shall we simply take that as read and note?
No, thank you, Kevin. Nothing specific to highlight, just here for information. Thank you.
Fab. Thank you very much, Karen. So that brings us to the end of our public board agenda. Thank you very much, everybody, for your contributions to that meeting. We're due to reconvene in private at 11 o'clock, so I will see those colleagues that are joining us then in 20 minutes time. Thank you very much.
Thank you.
Thank you.